You were saying during the news that there is a lot of work going on at the moment in this whole area, and that you know of about 250 separate studies that are trying to find some answers for dementia.
Yes, and those are just the ones that are recruiting people right now. So all over the world, there's a concerted effort recognizing Alzheimer's disease has got substantial impact on patients, their family, and the health system. And so there's a lot going on right now.
Peter, what about clinical trials of new drugs? Any proven success?
Unfortunately, Tony, the last 6 months has actually been a little depressing. A couple of trials that had been advancing. So clinical trials, first of all, want to show that the drug under investigation has the desired effects. That's usually a measure of improved cognitive function or a lack of decline. The drug has actually stopped the decline. Later you do a much larger study which is looking to make better insights into the effect of the drug, but in particular looking to make sure that it doesn't have adverse side effects. And so two compounds that were going through that latter stage, looking for effect but also side effects, fell over. They didn't show the clinical effect that had previously been seen. That's very disappointing for everybody. It's disappointing for the community that is very much hoping for the breakthrough that so many scientists are working on. I think it's also very disappointed for the people that are conducting and sponsoring those trials because
very expensive.
They're stumping up a fair bit of money because they're making an investment. They have to understand an investment is a risk, but they're making an investment trying to find that cure.
It's one of those situations with research, I guess it's largely happenstance. 9 times out of 10, you just sort of working away and all of a sudden something falls in your lap often.
Yes, I mean, by the time these clinical trials get to this stage, there's a lot of data being collected in the laboratory, in various systems, perhaps in experimental animals, before it has even gone to being administered to people.
Yep.
But even so, you do have to look for those rare events. I mean, everybody would love to have a drug that could treat dementia, but most people would say if even just a fraction of a % of people had a severe, catastrophic side effect, that risk would then be too high for all the benefit. So developing drugs is a very challenging discipline.
Is anything looking likely at the moment? I mean, you say a couple of big ones have fallen over. Anything coming through that you think, oh, well, that could be an important thing?
Well, as Clement mentioned, there's some 250 odd trials around the world that are recruiting individuals.
Everyone is in there pitching.
And exactly. There are several sort of dominant theories, if you like. That the Church of Dementia researchers has been divided, some say, into Taoists and Baptists, depending upon which particular protein that deposits in the brain and is involved in the cause of the illness you particularly follow. Sounds almost like football teams, doesn't it?
It does a little bit, yeah.
But what that means is that the people in those particular thoughts or schools of thought pursue the lines that they think are going to work because of the type of interest that they've generated. The Baptists, the people that look at the amyloid that deposits in the brain, have progressed. Some of the studies looking at immunisation. They're still not clear and definitive, but they are still progressing. And a number of drugs that are in investigation, probably the largest single group, looking at how the amyloid, the protein that glugs up in the brain, is produced or how you might be able to stop it, are all progressing along.
But at the moment what we've got is something that will help you to deal with the symptoms rather than actually cure you.
The current medications we have slow the progression of symptoms. Unfortunately, they don't stop the symptom progression and they don't halt the disease. That means that they're useful and beneficial because they can slow progression, but they're not a cure. So they're clearly not sufficient.
Clement?
I mean, having said that, most of the diseases we deal with don't have cures. So you've got diabetes, you're not cured of it. You have your symptoms managed, same with asthma. So there are certain medications that help with the symptoms, as Peter said. And, we all would like a cure for Alzheimer's disease, but in the meantime, it's important to remember there's still many things that we can do.
Yeah. What about, Clement, the scans of patients' brains? Are they telling us any more than what's actually going on inside the brain about the cause of dementia?
Indeed. So there are two sort of main streams of imaging. One is looking at the shape and the structure of the brain through MRI scans, and one's using nuclear scans, particularly tracking where some of the abnormal protein amyloid is in the brain. And both of them give us early markers of disease and also help us shorten the time we need in clinical trials.
Is this science enabling us to perhaps look at other preventative measures down the track, do you think? Or?
Oh, absolutely, absolutely. Yeah. And preventative studies have been difficult because you have to run a study for a long time for a lot of people before you get enough people getting dementia to make it meaningful, and this would help shorten that process.
Sure. I just want to talk to you briefly, Clement, about what sort of support does a patient need when they're first diagnosed with dementia? What sort of action is the initial support that's required?
Yes. I think one of the most crucial things to remember is, if someone is diagnosed with early Alzheimer's disease today, they're still the same person as yesterday. They might have impairment in memory or language, word finding, but there's still many aspects of the cognition that's normal and useful and enjoyable, and we need to emphasize those.
I suppose you've got to, as carers and family members, put your seatbelt on, because sometimes you're going to get some things that you don't expect. I was talking to a friend the other day who has a parent who's got Alzheimer's, and they were entertaining guests, and the parent turned up semi-nude in the lounge room, and it obviously surprised not only the family members but also the guests, and it was one of those things where dealing with that is difficult, I guess.
I mean, it can be challenging and heartbreaking to look after your family with Alzheimer's disease. A lot of people would say, this is not the person I married, or this is not the person that I knew as my parent. And we're continually impressed by the resilience of families in looking after their family members.
Is it important to keep the routine as stable as possible? Is that an important part of the equation?
Yes, for a lot of people that's an important part of a daily management. Routines help people with dementia feel comfortable with what they're doing. Other things that might be helpful is talking with other carers in the same situation. I learn just as much from carers of people with dementia as I learn from the books. And there are also support groups and telephone lines that Alzheimer's Australia organises, which would be very helpful.
Is there enough respite care in this area? A lot of carers say that it really is challenging 24/7, 365 days, and that life becomes very tedious.
Is that a leading question, Tony? Of course not. Yeah, I think. Particularly in more challenging circumstances, whilst respite care could be available somewhere in the system, often there's not enough locally, and they're often not timely enough, particularly for younger people with Alzheimer's disease and other dementia.
Peter, how young can you be when you get Alzheimer's? I mean, is it possible early onset?
Well, the early onset, the genetic forms, which, as Clement said earlier, are really incredibly rare, do strike very young. I think the youngest Australian that we've been involved with studying was in their 20s.
That must be a terrible ordeal.
Now, that's you've hardly finished growing up, and you're sort of on the decline down. However, most people with the early onset forms of dementia have them present in their 40s or 50s. Even so, the 40s are the new 30s and the 50s are the new 40s. These are the prime of lifetimes for people. They've got typically young families. So all of these issues that we've been talking about, which might affect somebody at a slightly later stage in their lifestyle or their lifespan, are actually there very early.